tutorial.
Okay, good afternoon or good evening, depending on where you are. We took long to research, and this time around, we decided, we have chosen gout, and we will see the reason why we went for gout. Dr. Muller, my slides are not moving.
Just click on the slide itself, just move your marker around and see if you click on the slide itself. Sometimes if it's too high, the marker, you're managing. Otherwise, you can unshare and try and share again. But just try and see if you clicked on lower down on the screen, if that works.
What is happening today? Okay.
Well done. Great.
It went far. Okay. So this is a patient that we'll be talking about. It is a 50-year-old male patient with schizophrenia attending Ward 13, but who is also getting treatment at Ward 5 for gout and hypertension. So it's just for us to be mindful that any day, any time, any month, we can get a patient that come to us as a scheduled follow-up. And how do we deal with such patient? So his prescription, latest prescription in the folder was Gout Care or Gout Care Pack. We'll discuss this next week. Citalopram 20 milligram, haloperidol 3 milligram notte, enalapril 5 milligram once a day, and allopurinol 300 milligram per day. So unfortunately, this was not supposed to be having that found. So at this stage, he came to us and that is what was supposed to be there. So he doesn't have any arthritic symptoms. So he is pretty having all his joints that are painless, that are not swollen. So I think that one of the main question will be, I need to rescript this patient. I never saw this patient. I never diagnosed this patient before. And what should I be looking in the note to find out that the diagnosis is right so that the prescription makes sense? So is it really gout that I'm dealing with or not? So we all know having painless, not swollen joint is not uncommon with gout, because as you can see, we might have caught our patient in what is called intercritical period. So the period between two flares, because as we can read in some of our patient folders, they would have experienced flares before, and we are just lucky that on the day that they came to us, they were in that period. And intercritical period are most often entirely asymptomatic. So we cannot reconsider the diagnosis just because our patient was not having any tender joint or any swollen joint, especially early in the course of the gout. You might have a patient that doesn't have any sign or any symptom about gout. And this intercritical period have variable interval duration in between, and they come, they recur quite frequently. And once a patient has gout and that patient doesn't have treatment, the flares becomes more frequent, they take longer, and they become more severe. And that is one of the reasons why we put them on treatment, is to try to reduce the frequency of flares and get them to be comfortable and live their life without pain or disability. So the question was, is this gout that will be prescribing for just this history? If talking to the patient, you can locate now your patient and identify that consultation as a consultation that is happening during intercritical period. Just that fact is highly suggestive of the diagnosis of gout, because rheumatic wise, there is very few diseases except for crystal related arthropathies and palindromic rheumatoid or rheumatism. You will never see patients that go through intercritical period. But because we're still talking about, is it gout or is this not gout, it means that we should be mindful of how do we ourselves make a diagnosis of gout. So what else is more highly suggestive of the diagnosis of gout is arthrocentesis. Because when you tap your patient and you send the specimen for monosodium urate crystal, you know that by tapping a joint, you are more likely to make your diagnosis. You tap the synovial or the bursa fluid, and you send it for not only the crystal, but also cytology and microbiology, just to make sure that under inflammatory arthritis, you don't miss septic arthritis. If you get the monosodium urate crystal, you know that the sensitivity of your arthrocentesis will be 85% and 100% specific. So every single patient that you get, you offer a tap and you get a report back of monosodium urate crystal, you are almost 100% sure. You are 100% sure that you are dealing with gout. So, but if you don't have access to arthrocentesis report yet, what else can you do to diagnose your patient with gout? It means if you cannot tap it, or if you tap it but it's not yet back, what you need is to consider the possibility of scoring it. And scoring it, we don't score only rheumatoid arthritis, even gout as a scoring system for you to get to gout diagnosis. And the first entry, as you can see in that scoring system, which comprises the 3 steps. The first entry is that you need to get your patient with at least 1 episode of swelling or tender peripheral joint or bursa. So when you receive your patient, even if everything was not documented properly, or even if your patient was coming from the private sector or coming from another institution and the referral letter didn't stipulate, gave the full, describe the previous episode, you might inquire from your patient about the history of at least 1 episode of swelling and or tender peripheral joint or bursa. So basically the first step in the scoring system relates to the existence of flare. And we know the flare can be typical, and we need to be able to remember and discuss with the patient, or as we inquire, the specifics of a typical flare. But we also know that flare can be atypical, and they might not involve the joint that we always think of, and can be mild, not as severe and as sudden as the flares that we expect from the patient. Why is it? Okay, and at the time, we always think of gout as a monoarthritis or as a oligo-inflammatory arthritis, but we need to be mindful of the fact that as the flares increases, as time goes, when patients are not controlled, you might have a polyarticular pattern of flares. And as we were saying again, at least 80% of typical flare will involve the lower extremity, and most often it will be at the base of the great toe, the first metatarsophalangeal joint, known as, that is what we call, what we know, or what is known as podagra. So these are the other ways that gout might present, and there have been a lot of patients that were misdiagnosed, or the diagnosis was delayed just because it was the ankle that was involved or the instep that was involved. And again, as you can see there, you can have a flare of the wrist, the finger, the olecranon, and just even the shoulder or hips can be involved. So it is not always the first metatarsophalangeal joint, although it is the most commonly joint that will be involved in a typical flare in more, at least 80% of cases. So another characteristic of flares that we need to remember is that the swelling or the inflammation usually goes beyond the joint. That's why at the time people start considering the possibility of cellulitis, of considering the possibility of even a DVT, just because the inflammation in gout tend to go beyond the confines of a joint. It is arthritis, but let us not forget that whenever we ask or inquire from our patient, or whenever we examine our patient, the fact that the inflammation might be far away from the joint doesn't take away the fact that our patient are going through gout or are experiencing a gout flare. So we're talking about the 3 steps. So the first step being basically a flare. The second step will be to get sufficient clinical criteria that basically it is the presence of monosodium crystal in a symptomatic joint or bursa, or the presence of a tophus. So you inquire from the patient. This patient comes to you for the first time. You need to renew the prescription for you to be comfortable that you've been really dealing with gout and you will have to carry on the management, is to inquire about flare, remembering what is typical flare, being mindful of the fact that you can have a typical flare or a typical a joint that might be involved, and even a typical presentation. But the next step will be, can you get this crystal, or can you look for the presence of tophus on your patient? So basically, if these 2 steps are met, you can already diagnose your patient with a flare. So this means we should all learn to tap, to put the needle in a joint to try to collect synovial fluid or bursa fluid to send to the lab in a aseptic manner so that we don't infect somebody's joint, but for us to be able to determine that they are crystal present. But failure to have 1 and 2 made, then you need to bring in the third step, which is basically a scoring system that will let you to score your patient, and only when they get at least 8 points on that scoring system, then you can diagnose your patient with gout. Those are the criteria that you need to use to score your patient. They are clinical criteria, meaning which joints are involved, what is the pattern of involvement, what are the characteristics of the joint involvement, the time course, the clinical evidence of toughness or not. Do you have access to the uric acid level? And did you have access to the fluid analysis? And all those things give you point, and you score your patient. If it is 8 or more, then you diagnose your patient with gout. The sensitivity is about 90%, same as the specificity. So you need at least 8 points on that scoring system to diagnose your patient with gout. So now that we know, we've reviewed our patient and we can be reassured that it is gout, or it was gout that was diagnosed before we took over, we need to remember that every single patient with gout will not only present with one condition. And up to 10% of patients with gout will have at least 7 comorbidity. So just to tell you, we say we will be talking about gout. Now we need to get prepared to deal with more than gout, because we will not always have, or will not always be lucky to have patients that will only have gout alone. So, and these are some of the diseases that you will find in a patient with gout. And this is the case of our patient. Our patient had hypertension. Our patient is known to Ward 13, and our patient has many of South African individual as metabolic syndrome. So this again, it is remind us of the value of the anthropometrics. How many of our patients are we weighing? How many of our patients are we checking their height? How many of our patients do we even check the abdominal circumference? Talking about metabolic syndrome, talking first about hypertension, we must know that 74% of patients with gout will have hypertension. So even if this talk was all about gout, or started as a talk of gout, just because 3 out of 4 patients that you diagnose with gout will have hypertension, you cannot, or we cannot afford to say, I will treat, or who will be able to treat or manage gout appropriately, but ignoring one of the commonest comorbidity that is most likely to be behind gout. And metabolic syndrome again. I hope we are all familiar with the criteria that makes somebody qualify for metabolic syndrome. It is all about getting any of three of the following. So triglyceride, your patient HDL, your patient blood pressure, your patient fasting blood glucose or plasma glucose. But when it comes to triglyceride, HDL, and fasting blood glucose, the refined definition currently include also treatment. So every single person that is treated for hypertension meet one of the criteria. Every single person that is treated for diabetes meets one criteria. So, and every single person that have treatment for triglyceride meet the criteria. And as you can see, waist circumference is one of the criteria. So it's, we should, how many times did we have an assessment of metabolic syndrome documented in our patient files? And how commonly or how not uncommon patient that we deal with gout or not will meet three of these criteria and should be considered and labeled metabolic syndrome for us to take care of them accordingly, because this is a cardiovascular risk. This patient lives with high likelihood to experience stroke, to experience heart attack, and all other complications pertaining to high cardiovascular risk. So it is also now critical for us not only to be writing HDT, HGT, HG, it's blood glucose. Is it fasting or random? Because we usually just write blood glucose or HGT, but until we get to appreciate that it should be documented that it was random or fasting, we might never make the determination if the patient is not known to have diabetes and being on TB treatment, on diabetes treatment, we might never make a determination that our patient has a metabolic syndrome. So why it is important for us not only to focus on gout and remember that they are overlapping diseases is that when you see gout, that is your opportunity for screening. It is mandatory that whenever you see gout, you screen for all those diseases that can come along with gout. That is an opportunity for you to detect those conditions as early as possible. This is also an opportunity for you to start aggressive management. It's only when we screen, we detect early, and we aggressively manage those conditions that we will ultimately improve our patient outcome. It will not be only preventing flares from happening. It will not be only getting your patient to be able to run, but make sure that every single other comorbidity is taken care of for us to improve our patient outcomes. So why was it also important that we bring up hypertension? It's not only because it is present in 75% of patients with gout, it's just because the treatment of hypertension can increase uricemia. And although we know that diuretic has a role to play, an important role to play when we deal with hypertension, we should also remember that diuretic can increase uricemia. And diuretic use is an important risk for gout per se. And we all remember about hydrochlorothiazides none of us will ever forget about hydrochlorothiazide and gout, especially that even the table, the famous table in the South African hypertension guideline under contraindications and the special indication in special circumstances single out hydrochlorothiazide as a contraindication, gout as a contraindication for gout as a contraindication for hydrochlorothiazide use. We need to remember that furosemide also can increase uric acid level. And it is unfortunate that we've been always that furosemide is not listed in that famous table in the guideline. We many times will stop hydrochlorothiazide, but switch for gout, but switch the patient to furosemide. We need to know that the risk for the patient to develop, to get uric acid increase and even develop gout is even more strongly related to loop diuretic use than thiazide use. So please don't run from the rain to go and jump into a river or jump in a sea, because that is literally what we do when we stop thiazide and run for and prescribe the loop diuretic to our patient in the context of gout. And it is also shown that when patients have CKD, even spironolactone can lead to increase in uric acid. This is one of the first reports that showed that there is a plausibility for spironolactone in a patient with CKD, possibility that spironolactone could increase uric acid. So we spoke about this already, why it is important, gout and hypertension, for us to remember the link. Not only it is common, not only there are drugs that we use for hypertension that will increase uric acid, but also whenever we have gout and we want to treat hypertension, we need to remember that if you take the Australian guideline, or if you take the South African guideline, or if you take the European guideline, gout is registered or is listed as a compelling contraindication for the use of hydrochlorothiazide, and should also be considered as a compelling contraindication for the prescription of furosemide. But when you go into and when you review or read the guidelines from America, for example, they will tell you it is not a compelling indication. You just need to be cautious when you prescribe hydrochlorothiazide, and you could still use thiazide in patient with history of gout when the patient is on uric acid lowering therapy. So if your patient is on allopurinol based on American guideline, you can still use hydrochlorothiazide. So if you see one of the colleagues using or keeping hydrochlorothiazide while the patient is known to have gout and the patient is on allopurinol, just understand that that colleague might be coming from the side of the American guideline that don't compel people not to, or clinician not to use hydrochlorothiazide. So we've spoken about furosemide, that increases the risk of gout. It is not only hydrochlorothiazide. And talking about furosemide again, furosemide is not a first-line therapy. It might be the reason why it was not listed in that table, but it doesn't mean that furosemide cannot cause gout or make your patient gout to worsen. And it is not a first-line therapy when you treat your patient with hypertension. And we need to know that they are just limited indication where you will consider to prescribe furosemide for your patient. Unfortunately, Amatole district is one of the districts in this country that has the most patient on furosemide for hypertension outside of the limited indication that are known to be applicable for that purpose. And which are those limited indication for the use of furosemide to treat hypertension? It is that you can only reach for furosemide instead, not in combination, instead of thiazide, because thiazide becomes less effective. It is when the eGFR is below 45 ml per minute when you are in South Africa and in Europe, and less than 30 ml per minute when you are in America. Or the other limited indication where you might consider furosemide for you to treat hypertension, it is when your patient has heart failure, or when your patient has pulmonary edema, or when your patient has body retention. In the absence of these limited indication, no patient should be offered furosemide to treat hypertension. Remember, furosemide, which is known as Lasix, because it lasts 6 hours only. That's why it is Lasix. So cannot be given to the patient. And whenever we prescribe furosemide, even when the eGFR warrant the use of furosemide, we should remember to prescribe it as a BD dose, not as a once daily dose, considering the fact that the half-life of furosemide is very low. So not only we prescribe furosemide when it is not needed for hypertension, but whenever it is even indicated, we tend to forget to prescribe it appropriately, because most of these patients in Amatole district that are on furosemide are given furosemide once daily, which is not a schedule that we should offer to our patients for hypertension. So we spoke about this. These were the numbers of our patient. Again, we know hypertension, but at the time we don't even know how to diagnose or follow all the rules to diagnose our patient properly. So these are the reading of our patient. And one of the comments in the folder, it was that because it has been more than 6 months, therefore our patient was supposed to be diagnosed with hypertension. And remember, when we said we needed to know these comorbidities for us to be forced, because it was said it is mandatory that we screen for those conditions and we detect them early. And I don't think that all of us or any one of us would say diagnosing hypertension 6 months down the line is early detection of a condition that was in this particular patient. This is the reason why I thought that it is critical that we remind one another the criteria for diagnosing hypertension. There are things that we take for granted. You see, this patient lived 6 months of his or her life without the diagnosis, and meaning without the treatment, that will reduce this patient's cardiovascular risk. So the blood pressure must be elevated. It should be persistent. That's why we need to repeat this measurement. As you can see there, it is about 2 to 3 visits. The one in red are the numbers that are, or the criteria that appear in the 2014 South African guideline, an interval of 4 weeks, but today things have been refined to say depending on the BP level, because if somebody has the blood pressures that are above 160, just below 180, why would you keep that patient for 4 weeks before you repeat? So that's why at time you need to go quicker. Remember, it is all about early detection or early diagnosis. Patients that have blood pressure that are elevated can get day numbers repeated within a week or at a week interval, so that as quick as possible, you diagnose your patient with hypertension and you start the appropriate treatment. The only exception to the repeated is, we all know, grade 3 hypertension that will be diagnosed in a single visit. And whenever we want to diagnose, we need also to appreciate how critical it is for us to accurately measure the blood pressure. Just keep in mind what is written there. 1 in 3 patients with blood pressure numbers might have numbers that are not accurate, just because all of us, being doctors, nurses, we all perform poorly when it comes to measuring the blood pressure, although we know that those numbers are essential for us to diagnose the patient, although we know that those numbers are essential for us to decide if our patient is controlled or not, although we know that those numbers are there to make us appreciate that our patient is at risk of complication or not, but yet we are very casual when it comes to how to measure the blood pressure. How many times did we take blood pressure? Three times before we get to the last to the average. How many times did we even average? How many times did we follow the protocol? Because it is not only about did we get the correct machine that is validated, that was calibrated, did we have the correct curve, did we allow our patient to rest, and did you go through all those checkups? But it's also about, at the end of the day, how many times did we measure? Did we discard the first measurement, and did we average the last 2? Did we even provide to the patient as that process was completed verbally and in writing the numbers? Did we even document the time that the patient last took medication for hypertension if the patient is on treatment? So, talking about treatment now, this is the treatment that was given to our patient for hypertension. 5 milligrams of enalapril once daily. And no blood was ever planned, scheduled to be done after starting. So the patient went home for the full month and came back for follow-up with no blood done, while we know that every time we start a patient on enalapril, serum creatinine is expected to increase by 20 to 30%. And this usually occur within 2 weeks of starting the patient on enalapril or increasing the dose of enalapril. And some patients get this even earlier. Patients that we prescribe enalapril to and ibuprofen at the same time. So all those patients that go and buy ibuprofen, and this is also a patient with gout that is more likely to get NSAID. And we start on the enalapril, but we just don't care. We don't care about checking the patient renal function, because the recommendations are clear from the KDIGO. If you start your patient on enalapril, you should recheck potassium, creatinine, urea, and sodium within 2 to 4 weeks of initiation or dose increase. And you can only continue enalapril if within 4 weeks that change that is expected to be between 20 and 30 didn't exceed 30%. Now the patient is coming a month later, there is no blood done, and the patient must go back home with enalapril without us knowing if it is still safe for the patient to carry on using this drug. So, and talking about hypertension therapy again, this is one drug that was prescribed. What is the role of monotherapy today in 2022 when you deal with hypertension? There is almost no room for monotherapy. Almost. The paradigm shift from 2020 is that every single patient with hypertension should be considered or should be offered a combination therapy. This is not the traditional teaching. This is not what we used to do, but this is the shift. The same shift like going from efavirenz to dolutegravir. The same shift like going from D40 to tenofovir. Why is it that we can go for the best evidence and the best management for HIV, but yet still be negligent when it comes to hypertension, forgetting today that cardiovascular disease are the leading cause of mortality globally. And hypertension is one of these conditions that fuels cardiovascular mortality. So every single patient, and this is known, this is published, most of the patients with hypertension will need 2 drugs. Most of the patients, very few patients will ever be controlled with 1 drug. That was one of the reasons why the shift occurred. This is the data that are published. Up to 80% will respond to 2 drugs. That's why you need 2 drugs. Only 40% of patients respond to monotherapy, and only about 30% will reach blood control. We keep on going through the cascade of care of hypertension and lament the fact that it is so poor and disappointing that very few of patients on therapy are controlled. But did we even give them the chance to be controlled by providing them with the treatment that is more likely to get them there? And as you can see again, because only 30% will reach BP control, most of the patients will need subsequently 2 or more drugs for them to get control. That's why it is critical that from the get-go, patients with hypertension in 2022 are offered combination therapy, not monotherapy. And as you can see, it's only when we get to 3 drugs that we can expect up to 95% of patients to respond to combination therapy, to that combination therapy. So, and again, not only this is known, but it is also known that a combination therapy is more effective than high dose of monotherapy. These are the data to prove it. 5 times greater extra blood pressure reduction when you combine 2 drugs at half doses than when you double the dose of 1 drug, regardless of the class. This is again another way of just trying to convince all of us of how critical it is that our patients should be offered monotherapy. Not only it is more effective, but not be offered monotherapy and be offered combination therapy, it's because it is not only more effective, but it gets you there more quickly. And most of the time, most of our patients will tend to respond. It is not heterogeneous response like when patients are on monotherapy. And this is just another way of showing you how critical it is for the patient to receive combination therapy. Even when you adjust BRACE and say calcium blockers, calcium channel blockers works better in Black people, even when you profile your patient, as you can see there, whenever, even by renin activity, you profile them, but whenever you combine, you will get a better response than when you profile your patient and offer monotherapy. Again, the chances of achieving BP control, as you can see, they are more, it is 30% more likely to reach control, 34% more likely to reach control when you combine, and 53% more likely to reach control when you combine and offer fixed dose combination. So fixed dose combination should not be promoted only for ARVs. Fixed dose combination should also be promoted for hypertension, because we all know the lower the pill burden, the higher the adherence, and the better the adherence, the better the control. So those things are there, they are published, and today, if you go in private sector, you will see that there is a plethora of fixed dose combination, and almost no GP today or no physician in private sector will prescribe single drugs. They will choose single tablet regimen for most of their patients, not single monotherapy, multiple drugs for the patient. So, and again, how many times were we frustrated that we didn't get there, or the patient got frustrated? Get them combination therapy, they will get there quicker, they will get there in a short period of time, least number of visits, and they won't miss, or they won't disappear. At the time they disappear, because what is the point of me coming to the clinic? Because every time they check my blood pressure with the treatment they prescribe to me, my blood pressure doesn't go down. And the longer we take to control our patient, there is a price to pay, as you can see, being it in cardiovascular event, particularly stroke, or in mortality. So there is a need for us to reframe the way that we check, we assess our patient and we treat our patient. As you can see again, we started with gout. You know now the connection between gout and hypertension, and how critical all these slides and information is useful not only for our patient, but for us also in managing this patient that comes with gout. We'll continue next week. I think that we've finished the parts, the impact of hypertension and gout. We'll check all other aspects, being it dyslipidemia with gout, learning from this particular patient and the treatment that were offered to the patient or assessment that were not done. And keeping in mind that it should not be only about gout. Whenever you see gout, you need to see more than gout, because up to 10% of patients with gout might have about 7 comorbidity. Thank you very much.
Wonderful.
Dr. Muller?
Yes, I'm here. Wonderful. Thank you for just finding my mute button. Thank you very, very much. That was great. Just not just an update on gout and uric acid, but also on hypertension. Dr. Kabengele, I assume we're having another session next week, Wednesday. Is that right?
Yes.
Yes.
And
and what will we be doing next week?
No, we will carry on the same. We didn't yet manage. Remember that we didn't yet manage this patient with gout.
I know, that's why I'm just, yes, we are just a teaser for next week in terms of what we're going to do with management. I'd like to open the floor just if there's any questions or comments at this point. You can either put your hand up in the chat or you can just unmute and speak.
I don't know why people keep always quiet.
It's because you're so good, Dr. Kabengele. You've done such a good job, and we know we're going to do the next lot next week. So thank you very much. That was a very nice in-depth look at some very important issues, and we'll continue this conversation next week, Wednesday. Everybody have a lovely evening, and the recording will also be available for those of you who want to catch up and to give to those of you who didn't make it this evening. Good night, everybody.
Bye.